Let's get the windows going on and get rid of the participants window. Good evening, everybody. Like we've not been chatting for the last 5 minutes.
Hello, everyone.
Good evening.
Hope everyone is well. As usual, we shall do our sort of 2 minutes or so of chatting to give everyone a chance to get in, and then we will make a start. This is the COVID edition of us getting together and pretending we know what we're doing. So if anyone has any specific questions, then do please stick them in the comments on the thread, and we will do our best to address them. If one of the questions is going to be, can we still work, then yeah, we'll probably address that one. But, what's everyone drinking this evening?
I'm on lager.
Yeah, lightweight.
Ruby Hobgoblin.
Oh, solid choice. Solid choice. I haven't got mine out of the fridge yet.
Fridge.
Yeah. Session IPA out of the fridge.
I'll let you off then.
Yeah, well, you know, it's been a long day. Sometimes you want an IPA, but you also want something cold.
Mm-hmm.
That's. I don't think that makes me a bad person.
Not totally.
Not entirely. Right then, on Gould, we got 72 people already. Okay, so where shall we begin? I'm sure we all saw the announcement this evening. Isn't it lovely how they refer to Van Tam as JVT?
And yes, the standard little box.
Brilliant, yeah, it's wonderful. Next slide, please. And the upshot of it was that most of the country is now in Tier 4, with the exception of some bits of Cornwall and a garden shed somewhere in Wales.
In Wales?
In Wales, yeah. Not in South Wales. South Wales is
No.
very... schools have been suspended until the 18th, which is when the next official review takes place. The Oxford AstraZeneca vaccine has been approved today.
Yay!
Which is wonderful news, and will be being rolled out from Monday, doubtless with all the efficiency that they applied to the track and trace system, although we might hope otherwise. And things are generally a little bit ropey, but hopefully will be less ropey soon, I think is a fair summary, isn't it?
Yes.
I'd say so.
It's been a day of extreme mixed emotions, and people are very confused about what they're feeling, what they want to do, which is understandable.
Confused about the government guidance on coronavirus?
No, about
See my face of surprise.
individually and professionally, we should be doing. So
yeah, okay. So I took the liberty of dragging up the a few relevant web pages. I believe I have closed down the midget snuff porn window. So there we go. Get rid of that, and Tier 4 guidance. So, businesses and venues which must close are non-essential retail, hospitality, accommodation, leisure and sport facilities, entertainment venues, indoor attractions, personal care facilities such as hair, beauty, tanning and nail salons, tattoo parlours, spas, massage parlours, body and skin piercing services. These services should not be provided in other people's homes.
but you can do your own if you like.
Community centres and halls. You will notice that healthcare is not mentioned anywhere in there, and in the businesses and venues which can remain open, we still have medical and dental services. Oh, they somewhat fudge the difference between medical and health, don't they? And it's probably not a thing we want to go down. But I think I'm reasonable to say that this covers health services, does it not?
because somewhere else it does actually say medical and health.
I think it's on the graphic, isn't it?
Yeah, and the important point to note is that Tier 4 restrictions are not more restrictive than full national lockdowns. And the full national lockdowns certainly enabled health practices to continue functioning. So a simple basic deduction from that would be that there's no reason for anybody to feel like they've been told that they have to stop practicing or to cease. As we sort of discussed before we came on air, people have their own individual decisions to make as clinicians, which I think is fair. And you know, that advice and guidance that's been out for the longest time that talks about, you know, considering your patient's needs, doing that risk assessment, phoning ahead, PPE, all of those things obviously continue to apply. But yeah, absolutely, there's no mandate or no diktat that says people who work in health need to suddenly stop working, and there's been no sort of caveats put to that either, sort of saying things like you must be HCPC registered or any of that sort of thing.
Indeed. So the answer to the first bit very clearly is, in terms of government guidelines, there is no government guidelines that say that either podiatrist or FHP services need to close.
100%.
The next question, which I don't doubt is in a lot of our minds, is would it be wise to close or restrict our activities?
I think before you go down that road, we should mention the caveat that you should always still check with your professional body on whether you're insured to actually practice during lockdown or Tier 4, because I am aware that there is another professional body, the Institute of Chiropodist and Podiatrists, who have issued slightly different advice. So do check with your professional body.
I was aware of that.
Yes.
That surprises me, because the Institute were quite go out and lick door, well, not go out and lick door handles, but they were quite sort of open in their recommendations first time around, weren't they? It surprises me that they're...
I've actually got a screenshot if you want me to just quickly share it.
Yeah, sure.
That's helpful.
It is indeed. Do you need the ball?
Please. Can't do it otherwise.
You have the ball now.
Excellent. Can you see that?
Yes.
So doesn't really require an awful lot of comment, but I think it's good to share it. I'm sure Somas wouldn't mind us sharing it.
No, everyone
It's a
likes it.
statement which was put out for the attention of all insured IOCP members. So to take note, does say during lockdown. So I assume anything, can you, whether it's Tier 4 or not. So do check with them.
That's
you are
dated the
insured.
5th of November, so it might be different. 5th of November is about 200 years ago in COVID time. Yeah, okay, well, maybe somebody could check with the IOCP. I don't believe that the gentleman is returning my emails at the moment, so maybe somebody who is still with them can comment. But yeah, certainly speak to your professional body.
Absolutely. I need to throw you the ball back.
Okay. That's fine. So the next question is it wise? Is it good? Is it wise? Is it helpful? Is it kind? I think that for me, it comes back to the same sort of questions we were asking ourselves first time. What is the risk to this person of coming in and seeing you versus what is the risk to this person of not getting their feet done? There is one little difference for me this time, which is that we have now got, at the risk of sounding like Mr. Johnson, the light at the end of the tunnel. We do know that there is an end point to it now. It's not an open-ended thing. So Yeah, I mean, what's everyone's thoughts on that?
In terms of, is it wise? I mean, it's going to be individual decisions, because you have to think about, any of our members, or speaking in that sense, but anybody who's practicing, who is looking at their own health and their own frailties, their own vulnerabilities. Maybe they lived with vulnerable people. They're going to be taking different decisions to those who maybe are not personally vulnerable. So there's all of those thoughts. I suppose the way I see it, and I suppose something we will get onto when maybe we try and talk about the broader picture and we think about certain hotspots where hospitals are struggling a bit at the moment, is that it comes back to that point that when you are making those decisions on seeing patients, if you are seeing any patients where you think about not seeing to their foot care needs, could quite feasibly, in a short window of time, lead to that patient needing to go and see somebody in hospital, then that's a very real consideration to make and think, could my actions avert that outcome? That would actually be a very wise and sensible decision to see them, particularly in the context of PPE. But of course, you may be looking at certain patients, lots of vulnerabilities, lots of frailties, and actually, based upon your pre-consult over the phone, their foot problems are not particularly pressing at this time. I think that's just going to be, I'm not going to dictate what people shouldn't do, but I think that would be a mutual conversation between the practitioner and the patient in terms of what both parties are happy, comfortable, and deem appropriate. So again, as we've said with so many things, it depends. I don't think there is a one-size-fits-all answer to this. But just to sort of raise the point, and I know this keeps on coming up, and I see questions come up about different parts of the UK, their restrictions mean different things. To the best of my knowledge at this time, I haven't seen any of the 4 nations of the United Kingdom stating within their higher levels of restrictions that certain health services need to stop. They do all make the point about personal care services and what might be considered cosmetic services. But for the most part, the majority of the FHPs that I'm aware of are not cosmetic practitioners. They're not providing beauty treatments. They are providing a health service. So that really needs to be the barometer that we all look at and think, am I positively influencing somebody's health, physical health, with my treatment? And if so, and if it's quite a pressing need, then with the right precautions in place, I think the risk levels are low in that context when you are balancing risk versus potential, benefit.
As always, one size does not fit all. I think your point about a telephone consultation to assess that risk is a very reasonable one, and something that we should record on our notes as well. If you have spoken to your patient and risk assessed, risk of non-treatment deemed higher than risk from COVID, patient to come in, then that would certainly be good from a legal point of view and from a point of view of nudging you to think in the right sort of direction. Yeah, I think that's reasonable.
And I think it possibly at this point is just worth just clarifying a few points. I think one of the things that I've definitely found during this entire episode, shall we call it, is that there's been a very, very significant sense that people have struggled to contextualize risk. And that's a very, very difficult thing for people to do, but it is important because first and foremost, and there's many papers to this effect now, this isn't just sort of speculative, the actual secondary attack rate, they call it, which is the likelihood of somebody passing an infection on with somebody who's completely asymptomatic, is actually an exceedingly unusual occurrence, and it needs prolonged non-PPE contact to occur. So if you think about the context in which you provide health services, if you are an entirely asymptomatic individual, you are doing your PPE, you're minimizing the time you're with that patient, the likelihood of transmission, statistically speaking, is remarkably small. And that is worth keeping very much in the forefront of our minds, because we can quickly get into this mindset that we are very, very, very highly contagious individuals without so much as a cough or a sniffle. And therefore, we shouldn't be in contact with anybody virtually. And it is just worth sort of, bringing that into some sort of some sort of relevance, I think.
Yeah. Yeah. No, you're right. You're right. One of the Rubicon moments for me was in the NHS. I've had to see people in a home where there is a COVID sufferer and go in wearing PPE, which of course was fully the PPE that we should have had. And I did that 3 times during the course of that and was fine. Our PPE does work for us and for them. There's a bit of a tension for me in that on the one hand, you look at how quickly this is spreading in spite of all the precautions, and you think, well, wow, if it can still do this with all the lockdowns that we've had, it's got to be pretty contagious. And then you look at that evidence, which you're quite right is clearly there, which says you've got to basically lick somebody's eyeball to get it from them. And there's a bit of a
asymptomatic, yeah.
There's a bit of a dissonance between those two things. Are there a load of symptomatic people who are still going out and coughing on each other? Are people that's yeah?
Well, I think the really
you just answered that.
Yeah. Anytime you end a sentence with "are people that stupid?"
Well, there's that. The interesting thing is, if you recall back, and this is what is always important to do, is always to remind yourself of how the understanding and how the knowledge has changed and meandered over the entirety of the thing. So if you recall right back at the beginning, the primary believed mechanism of mode of transmission was, we used to talk about fomites and droplets, and it was all about hand washing, not touching the face. Well, more and more studies have now come out which have shown that actually that's very much a secondary route of transmission, and that probably, as many people may have expected from the outset, it is primarily aerosolized transmission which happens, which if you then put that into the context of other respiratory diseases and include even things like measles, albeit this is a rare occurrence these days, I know measles is highly contagious, but somebody walking into a room who is symptomatic with measles and who may cough, if somebody walks into that room within an hour of that person being in that room, they're likely to contract measles. Now, COVID is not that level of infectious. The R number isn't that high. But actually, the likelihood is that it is actually carried in the environment. So you may have had somebody who is or was symptomatic within a building, within an environment, who perhaps is the super spreader. But that super spreader might not be somebody who you necessarily knew that you had direct contact with. So I think there's probably an element of that going on, that there probably are some symptomatic persons. You didn't have prolonged direct contact with them, but maybe you had indirect contact with them over a prolonged period in a confined space. Hence, nosocomial infection being the massive driver of this. The admission numbers in hospitals are heavily influenced by people who are contracting it in hospital. Now, anybody who's been in hospital will know that. Sorry?
7% of cases in hospitals?
I think in certain trusts, it's north of 30% of cases were acquired in hospital.
And that brings us on to the risk balance as well. Just share a screen again. Bear with. So this is, it's interesting how the graphs that I've been following have changed over time. The patients in hospital is the one which is presently occupying my attention. Which you can see there, we're now here, we're higher than we were back in the peak in April. A couple of observations I would make there. One is that we are significantly higher. Two is that the really high levels do seem to be concentrated around London, South East, South Wales, and a few very local areas. So if you're in London, this is probably worse than it looks. If you're in leafy Hampshire, you're probably not too bad. The other thing that occurred to me is that back here, we were not very good at keeping people alive. We had a lot more deaths per cases, a lot more deaths per cases. And of course, that's a bad thing for the people who die. But from the healthcare point of view, if you go in, you're sick for a week and then you die, you've just freed the bed up. Whereas now we're better at keeping people alive. So we might well have a lot more people in hospital for longer, because we're better at keeping them alive, which puts more pressure on the NHS. And this is the thing, that if you have a heart attack or a broken leg or bacteremia from an ingrowing toenail or a diabetic foot ulcer that happened because you've not had your foot seen, this is still a very bad situation. There will be people this year who will die as a result of COVID who never actually got COVID.
Yeah.
I'm just going to add a couple of observations on that point about the hospitals, actually, just because I've been looking at this quite closely the last couple of days in particular. And there's just a couple of other sort of contextualizing points that I think are important. I think the first one to bear in mind is that what was particularly important to note about the peak in April is that was a very unusual number of people in hospital in April.
Yeah.
We do have each year, and I'm not trying to say this is just always the same, but we do have in December and January peak hospital number of people in hospital. And actually, when you look at 2018, 2019, 2017 and 2020, the actual crude numbers of number of people in hospital is actually very consistent. Now, of course, what the added pressure, the problem that we have now, of course, is owing to people testing PCR positive. There's quite a number of doctors and nurses who are isolating, which is obviously having a huge impact on staffing. And then, of course, when patients come in, we are routinely testing all patients now, both upon admission and those inpatients are being tested several times a week for COVID, whether they're in with respiratory symptoms or not. So the other thing that you're going to be finding is the number of those patients, included in the admissions for COVID now, just wouldn't have been picked up in April, because anybody who was in hospital for non-COVID reasons in April wasn't being tested. We didn't have the capacity to test. So there is going to be some noise in those numbers, I suppose I'd say. But you're absolutely right about the point that people are essentially not succumbing, thankfully, in a sort of mortal sense to the disease in the volume that was happening back in the spring. So you are going to be having, as a consequence of that, patients who are probably in hospital for longer, which is actually therefore building the sort of numbers who are there. But of course, you're quite right to say that the real consideration we're looking at is the impact this then has knock on for those who are having heart attacks and strokes and whatever else. The only hope we can really have with the situation in London is that it sort of follows the patterns that we saw in the northwest and the northeast, where you did have a couple of weeks where it got quite hairy, and then it did taper back down again, and got more manageable. And hopefully, as we enter into the new year and things like the vaccines start, becoming more of an effect on this sort of thing, we might see that start to calm down a bit.
Yes, it screws you both ways, doesn't it? It does increase the number of people who are sick in hospital, but it also drastically decreases the hospital's capacity to treat the people who are in there. And of course, this is why the Nightingale hospitals are not a great deal of use, because an aircraft hangar full of hospital beds with no doctors and nurses in it is not a hospital; it's a sleepover, and that's the thing. It's not the logistical problem of surfaces to put people on, it's the logistical problem of the doctors and nurses to treat them.
I think Professor Powis on the conference tonight said actually what they're using some of the Nightingales for are those patients who've been acutely ill and who are basically in recovery and are getting better each day, that they're putting many of them in the Nightingales where you don't need the specialist staff. You can deal with sort of more ancillary staff looking after them as they recover. That makes some sense. So you're freeing up some capacity in the sort of critical care beds and the hospital wards that way.
The people that in the first wave they sent back to the nursing homes, didn't they?
And that obviously then caused our second bubble back in sort of late May that went really bad in the care homes. That does seem to be better this time. I think actually nursing home acquired infections seem to be much better than they were in the spring. They're still quite high, but much better than they were. So there appears to be some lessons that clearly have been learned.
Mm. The deaths graph is an interesting one as well. Where the cases for this area, the graph would look like that if you superimposed it. The deaths are remarkably stable.
They are. And the cases that started rising towards the end of lockdown, which obviously then spooked the government a little bit, and the cases that then obviously started to rise again as lockdown ended in England, they would have started feeding through into the death numbers by now. So there's a tentative encouragement that what has caused the cases to take off, some of it will be the new variants, etc., so far at least, does not appear to be driving up the numbers of people dying. That appears to be quite steady.
Yeah. And we won't really know if the new variant is equally or less likely to kill you for quite some while, will we? Because you need macro data to find that out. But it is not implausible that the new variant is less likely to kill you.
I think that's certainly plausible. I think, as we discussed ages ago, that
Absolutely.
as they reach becoming endemic, they tend to get a bit more.
The general nature of viruses when they mutate is they do become weaker in so much they're not quite so devastating their effect, but they can become more virulent, if that makes sense.
Which, of course, is why your humble human papillomavirus per verrucas is such a very, very successful, clever virus. And long after we have obliterated coronavirus with vaccine and all the miracles of medical science, the HPV type 2 will be laughing at it and saying, "Oh, you really overdid your yourself." Yeah. So that was about where lockdown happened. That was where it came out, and that was where. And it's going to go up again because we've not yet seen the cases from the people that got infected over Christmas. Won't have shown up in the numbers yet, will they?
Probably not.
5 days average to become symptomatic. They've then got to go and get a test, wait 2 or 3 days for it to come back. I reckon a big spike in the next few days, but
possibly. Although I'm struggling to know of anybody in my wider circle of people I'm in communication with who actually sort of really visited anybody at all over Christmas. I'm sure there will have been people across the country. Of course,
my friends are a lot more intelligent than my friends.
But then there was an epidemiologist who actually said Christmas holidays are, contrary to sort of your intuition, not a bad way to actually stabilize things like transmission rates, because what you would typically do is, bearing in mind a lot of social events are closed down, so we didn't have like loads of pubs open, we didn't have office parties, having those sort of events. People tend to, even if they have visited outside their household, they tend to restrict themselves, often within communities or within families. And so he was sort of arguing a theoretical point that it might not necessarily lead to the spike in the way you think it would. And of course, you've had schools, particularly secondary schools, closed for 2 weeks, so they've actually been with their own families more than they would have been previously. So
Yeah.
what the Christmas 2 weeks has done to anything, and it'll probably be about a week before we start seeing that in the numbers.
Yeah, it's interesting. There's a few questions in the comments. Do you mind if we go back to that?
No, please do.
Sarah said, bearing in mind that we have members from all over the UK, I assume it's talking about SME members. Are tier regulations for FHPs the same, or are they different, say, for in Scotland?
There are some differences, but I think really the key point in terms of the sort of exemption for healthcare workers, I don't think that differs really across the tiers because it's such an essential service. And I did see the question before that, which is also about courses still running. Did you catch that one?
Oh yeah, Alex is saying, are we still doing the biomechanics course?
So I can't give a definitive answer on that right now. I was trying to get some clarity before we broke up for Christmas. And of course, what's quite rightly pointed out to me was that, a week is a very long time in COVID world in terms of what's going on. So actually what's likely to happen on the very first conversations we'll have when we reconvene on the 4th as a management structure would be to give clarity on that. My thought would be that those who are attending for practical training purposes, i.e. their FHP training, that should be able to go ahead. You know, the clinic has been, you know, put in a sort of COVID secure setup and environment, and it has been operating all the way through from towards the end of lockdown 1 continually through. The difficulty might be about some of the in-house CPDs that we were tentatively looking at, because I think it may be more difficult to justify those meetings of small numbers. But again, that's one of the very first things we will do is clarify and make it clear to everybody who may be booked on to any of those how the land lies. So hopefully we'll be able to give you a firm answer in the next week.
Interesting comment here. According to the IOCP, we are not health.
There's a lot of discussion on all of the forums about whether FHPs are health, whether they're medical, whether we're medical, whether we're health. At the end of the day, legislation says medical and health can work. However, you've really got to speak to your professional body about whether you individually are insured to work. The argument of whether or not the ISCP says that you are not a health professional, if you're a SME member, doesn't have any impact on you at all. So you've got to check with whoever you're insured with, is the message.
I think it kind of depends on what you're doing as well, because podiatrists and FHPs both, we straddle everything from the one extreme of, you know, your diabetic foot ulcers down to, you know, I don't need my nails cut right now, but I quite like to have them cut, and I've got a bit of callus which is a bit sore. You know, low risk person, which could probably be considered as almost social care. It's almost case by case, isn't it?
It's as it was before, case by case. You know, that bit of callus, which may not have been painful to the patient, but you know, they have sensory loss and they've got an ulcer forming underneath. So this is where the telephone consultation comes in, as Andrew astutely pointed.
Are you saying that you need to get a full history and all the details of a pathology in order to formulate a treatment plan for it?
I think I might be.
Gosh, there's a thing. That's a thing that you're saying. You saying thing, person. Problem is, my local hospital are moving nurses from COVID wards then to non-COVID wards in the same shift. Yeah. NHS hospitals managing things badly? Face of surprise. Out of interest, Ray, PPE, are practitioners wearing masks and visors? Interesting question, or just one or the other? Obviously in aprons and gloves too. In the NHS, we've had our guidelines changed. We are now to wear masks and visors for all patient contacts.
All the time?
All the time. As I understand it, the function of a visor is to protect your eyes from direct spatter, which if your patient is wearing a mask, which they all should be, I don't fully understand how it happens. However, I have started wearing a mask and a visor for all of my patient contacts, with the exception of when I have to do really, really, really close-up detailed work and I can't see through the visor. I had to pull a piece of glass out of somebody's foot this morning, and I had to take the visor off because I couldn't see what I was doing closely enough else. But I mean, the guidelines for non-AGP practices are ambiguous, aren't they? They talk about if there is a risk of droplet infection. From an intuitive point of view, I would say if the patient is wearing a mask, you probably don't need to wear a visor. But from a belt and braces point of view, you can if you want. Are you all right there, Andrew? You're gurning.
Yeah, no, I think that sounds reasonable. I don't think from a respiratory pathogen point of view, a visor does a significant amount, but it's an extra layer, I suppose. It's an extra barrier. If it gives people greater peace of mind, perhaps.
Yeah, and that's not an unimportant thing for you or your patients.
Peace of mind, absolutely. Yeah. Jessie Ponsford's made an excellent comment here, that most people in care now, and she's concerned, and I know others have said this as well, that having had their first stage of the vaccine, their first shot, might get a bit complacent and people might not be so careful. But yeah, is this something we should be advising our patients, I suppose?
opportunity for good messaging, isn't it?
Yeah, I mean, I suppose it depends upon what people constitute as being careful or not careful. I think what's worth bearing in mind is we will know soon enough the impact that the vaccine is having on transmission, but we don't know it yet. That's sort of the take home. The data, and it's all to do with what endpoints they were looking at. So the studies, none of the vaccine studies were actually measuring transmission rates. They were measuring disease moderation. In other words, if people got COVID, A, did they get COVID, and B, if they did they get it much more mildly? Though those were essentially the study outcomes. And what they showed is that much fewer, is that proper English? Much fewer, I don't know, far less people in the vaccinated group developed COVID than those in the control. So they had a clear understanding that fewer people got ill. But the main thing they noted is those who did get ill, particularly the Oxford vaccine, I think not one ended up with any significant hospital intervention across all of the age groups that they were vaccinating. Whereas some of the control groups, a few ended up in ICU, a few ended up in hospital.
I'll stop you there. It was really interesting on this one. I geeked it up, so I wanted to know this because Mr. Van Tam had my geek musk tingling. There were two people in the vaccine group who were hospitalised across the
Okay.
study. There were about 12,000 people in the vaccinated group. Of those two people who were hospitalised who had the vaccine, the first one was detected positive 2 days after he had the vaccine, which means
he probably had that time to even take effect yet.
Infected before he had the vaccine. The other one was 10 days after, so he was
possibly
post-vaccine, but not the vaccine hadn't had chance to
work yet. And actually, if it's a 14-day incubation, you could have even been another one who got it before.
Could easily have been before. He was said that you should start getting some protection around day 14, but most vaccine 3 or 4 weeks to work.
About 3 weeks, yeah.
And
made and stuff.
Of those, as you say, no others were hospitalised.
Interesting, isn't it?
Whether or not they caught it, if the metric we're measuring is sufficiently severe disease to end up in hospital, that was incredibly positive. They also some detail about how we do want people to have the two vaccines. The two vaccines is the programme, but we want the most important thing is to get the first vaccine into people.
That's right, because the first one still confers a significant percentage of protection, even if it's not as optimal as it would be after two. So I'm almost certain that the vaccine will be shown to actually break transmission lines quite considerably, but we don't know that information yet. So certainly until we know that information and we know the level of protection that somebody has, and we're not going to be advising people to go start licking each other's eyeballs, but you have to, for me, this whole thing has been about trying to balance the different things. And I think actually it's not our place, I don't think, to be overly critical of patients in terms of decisions they make about whatever it may be. It's kind of not our place, although we can reinforce good messaging. But you may look at somebody who is quite frail and elderly, who's had 2 doses of the vaccine, so who all intents and purposes as the vulnerable individual is now largely protected from the effects of it. If they haven't seen their son or daughter in 6 months or 9 months, and there is an acute psychological problem there, you've got to look at that in a human issue, from a human perspective, and say, actually, if they went and visited their daughter or their son, or they had them come to visit them, you've got to try and weigh that up, because as I think we've said throughout all of this, and in all contexts, there is never no risk to anything. Everything carries a degree of risk, and absolutely, and the entire thing has been about trying to tread a path which balances the risks most appropriately. And criticisms or whatever, that's always an incredibly difficult thing to gauge. So, yeah, I mean, you're not going to want people being reckless by any stretch of the imagination, but, there has to be at some point or other an easing back and an easing away of the restrictions. And that has to be done carefully and judiciously. And really, vaccines have to be our way out of it, even if they're not perfect, even if they don't prevent everybody getting ill.
To be perfect.
No, it doesn't need to be perfect. It just needs to be reducing the risk.
Yeah, Brendan's made a really good point here, which you kind of touched on, that some of his patients haven't been seen for months, but it's the mental aspect of the visits that's as beneficial, if not more, than the foot health. And I think a lot of us can really identify with that with our patients. Particularly those who are shielding, who haven't been able to see their own family. And we can, in PPE, after doing the risk assessment. So it's something to consider.
Yeah, as always, a full and holistic assessment.
True word of the holistic, yeah.
Yeah, it's a good word. It's a very good word. There was a question here. Actually, before we go on to that, something that actually no, I won't. I'll go somewhere else. As a mother of 3 teenagers living in Tier 4 Surrey, sorry to hear that, Lisa. That sounds really rough. There's more. She's not just.
I can identify with that.
I have teenagers. We can relate. My clients understandably are nervous about me going into them, despite me wearing PPE and strict protocols. Can I quote the likelihood of catching COVID from me? No. You can't ascribe a percentage value. We don't have the data. The best you can say is that it should be very, very unlikely. You could reference the fact that for a teenager, what's got to happen there is the teenager has got to get it. The teenager has got to be asymptomatic for you to not know that the teenager has got it. The teenager has got to give it to you whilst asymptomatic. Then you've got to have had time to incubate it. Then you've got to be asymptomatic, but still capable of passing it on to them. Then it's got to get through your PPE, and then it's got to get into them. So whilst you can't give them a precise percentage value, each of those multiplies it down. Each of those multiplies the risk down. If you're worried about somebody else bringing it to you and then you giving it to your patients, they should be symptomatic before you're infectious, by and large. And it ties in as well. And you're quite right. I've seen this a lot of places. It's the typical scientist problem that when scientists say something accurately, people misinterpret it. What Mr. Van Tam said was, we don't know that the vaccine prevents transmission. What the headbangers read was, the vaccine doesn't prevent it.
Yeah. Yeah.
Which is not what he said at all.
Not what he said at all. Yeah.
As Andrew said, we know that asymptomatic people don't tend to transmit, although I'm not 100% sure, but that seems to be the evidence. We know that we've got a group of people who have a high degree of natural immunity who tend to not become symptomatic and not become transmitting, i.e. under 10s, because we've got good data that under 10s rarely transmit it. So it's not an unreasonable leap to say if the vaccine has made you asymptomatic, then you're much, 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 much less likely to transmit it.
It's also worth bearing in mind, and this is where the granular level of the detail is. Some of it is available if you look for it, but it's never presented as such. So earlier on we were talking about, you look at gross numbers of hospital numbers, but actually when you start breaking into it and looking at it in different contexts, it suddenly becomes a more nuanced picture. And the same thing is true that actually what's happened over the last few weeks is that there's been this enormous focus, particularly in the southeast, at school children being the sort of massive drivers of the pandemic in the UK at the moment. But actually, again, there's been many, many paediatricians who've really been delving into this. And actually, it's the founder effect that is playing out here. And what the founder effect is that actually during the month of November to December, when the national lockdown was in place, one of the very, very few places that was operating largely as normal, and I sort of stress that loosely because I'm aware that a lot of year groups were sent home and whatever have you, but what was largely operating as normal was schools. So when people were presenting with any kind of respiratory symptom of any description, there was a disproportionate likelihood that it was actually going to be in school people, because they're the only people who weren't leaving their houses, largely speaking. Who were leaving the houses and going to an institution each day. So all of a sudden, they'll then go to a school, and because there's maybe been 1 or 2 cases, they then test a very, very high number of people who may have been in contact with that child, who was typically other children. They may pick out 1 or 2 more cases from there, and so on and so forth. So actually what you end up getting is a very, very high proportion of the people being tested were children, which suddenly showed up that there's more cases in children. Well, they just happen to be disproportionately tested at that point in time. And this has actually come to light because the ONS data that came out yesterday has shown that in London and the South East, people aged 20 to 40 are by far and away the largest people who are testing positive at the moment. Now that schools have been closed for 2 weeks, it's gone back to the trajectory that it was looking like all along. That actually young adults, which makes a lot of sense for a lot of reasons, but young adults largely appear to be where most cases are spread. And we actually see that with most infectious diseases of that nature each year, because they tend to be the most socially mobile people, because they're going to work and they're doing this, that, and the other. A lot of elderly people typically may be less integrated into society day to day. And as you said, what we've known from day one, particularly in the under 10s, is that children very rarely get this thing. It's just been one of those. I personally think it's been a remarkable blessing of this particular virus, because it's spooky enough when it takes adults and elderly people, but when it starts making young children very, very ill, that really upsets a lot of people very quickly. And so it seems slightly illogical to me that all of a sudden, out of nowhere, kids were suddenly deemed to be these super spreaders, when actually, delving into it a bit more, it might have just been a little bit of a testing sampling issue during a period where schools are pretty much the only institutions still operating.
Does it not make sense that the kids would get it more because that was the only environment where they were operating?
Possibly. And to me, it always comes back to this central argument of asymptomatic, because and that's different from pre-symptomatic, and that's important, because pre-symptomatic people is where the notion of asymptomatic originated from in these studies out of China, where somebody actually at the time they passing it on hadn't yet become symptomatic, but 2 or 3 days later they were down with the fever and the cough and everything.
Yeah,
absolutely. But genuinely asymptomatic is, as we've always known, is pretty rare. And if you think about it, if we try and think about how we thought about disease pre-March, if you were technically inoculated with a virus or a bacteria, but you never got clinically ill, colloquially speaking, we used to refer to that as somebody being immune. They've come into contact with the pathogen. They've never actually developed an illness from it. Although that's not technical immunity, that is often how we would think about it. That somebody did not develop the illness.
The data we've seen from the WHO and whatnot saying that asymptomatic spread is rare, they're talking about asymptomatic spread, not pre-symptomatic.
Correct. They're talking about people who never developed any symptoms.
That's a really important distinction.
That is a very important distinction, because I hadn't made that.
Yeah.
That was why I was gurning at you when you were talking about how we can be asymptomatic. So if you've not yet become symptomatic, you can spread it, but that makes sense.
And the way that you'd be able to know that, what the WHO did, is that when people and basically they had to base it off of individuals who went on to become clinically ill, and then they contact trace back. And they contact trace back to all their contacts in the 10 days leading up to them becoming ill, particularly those who had prolonged close contact with. And what they were able to discern, that there were some people who separately went on to get ill within a couple of days of seeing that person. They might be considered a pre-symptomatic individual who at that time may well have passed the infection on. But it is actually exceedingly rare to find somebody who was both PCR positive, but who never developed any symptoms, actually being the kind of heralding case. And that's something, so often in the press briefings, Boris Natt will mention 1 in 3 people are asymptomatic. Well, that's a bit of a questionable statement, because what he means is maybe 1 in 3 people who've had a positive result didn't report any symptoms. That's a very, very different reality. That's
Then
not
you
one
go
in
into
three
your
people.
Layeristic two-layer probability calculations, but yeah.
But yeah, so absolutely clear distinction. The pre-symptomatic bit is
That makes so much sense, because I've read a lot of stuff about asymptomatic spread not being a thing, and I'm thinking, well, then how is it spreading? But pre-symptomatic spread, of course, is how it's spreading. That makes perfect sense.